Good morning, everyone. For those of you I haven't met, I'm Mallory Johnson. I'm a professor here at UCSF in CAPS. I co-direct CAPS under Margarita's leadership and with Susan Keglis. So I get the honor of moderating what we're calling our NIH panel. And so if I could ask those of you who have been roped into joining this panel to join us here at the table, that would be great. And that includes Willow. And Willow, I hear you've volunteered, or you were volunteered to join us.
Can I say something about that?
Yes. Paul wants to give a preamble. You've got a mic there.
Okay.
Actually, this one I'm afraid I'll break it.
So just real quick, first of all, it's unfortunate that Chris is under the weather and Chris Gordon from NIMH won't be able to join us. But I actually have a partial answer to what is next for Susan Newcomer and Willow Pequodon, because we have recruited them as former program officers and program architects within their institutes of NIMH and NICHD to join Rick Berzon and I for the Q&A portion of the session. And Rick and I have a small presentation to give, and then we'll go on to the Q&A.
Great. Thank you, Paul. So by way of continuing the introduction, you've already heard from Paul Gaist, who is from the, I want to make sure I get the division right. So Paul is from the Behavioral and Social Sciences Research Section of the Office of AIDS Research and the Office of the Director at NIH, and he will tell us more about that entity and where it fits into the larger NIH picture. We also have joining us Rick Berzon, who is a program director in the Division of Extramural Scientific Programs, basically a program officer, through NIMHD. So that is the National Institute of Minority Health and Health Disparities. And we're going to have Willow and Susan can join anytime you want. What we asked for these panelists is to prepare just a few opening remarks just to orient the audience to who they are, what their particular institute or center or division focuses on, and also prime them with a couple of talking points to focus on advice for new and for established investigators given the current HIV funding priorities and the state of the epidemic and the state of funding. And also, if they have any insights as to current or forthcoming funding opportunities that people should be thinking about and brainstorming. Other than that, what we're hoping to do is to preserve a good chunk of time for questions from you. So please think of your questions. This is a great opportunity to have NIH officials here. And we've got a great range of perspectives, both from the OAR, as well as from particular institutes, and both current and former program officers. So with that being said, I will turn it over to Dr. Paul Gaist, who will talk to us about his role in the OAR, and we'll go from there. Thank you, Paul.
Thank you, Mallory. And good morning to everyone. And Susan, thank you for the great kickoff. And when we get to the Q&A portion, I've scanned the room, and I don't think there are any other program officers, feds here, but if I've missed you, please let me know and come up for the Q&A session. What I would like to do first is pretty much do two things. Figure out where the laser pointer is. Okay. And this is also going to progress the slides. Okay, thanks. So is to first give a brief presentation that's an orientation. Many people in the room are going to know much, if not all, of the first part of this. But this really, we had a great mentoring day ahead of the main meeting with the early career investigators. And in case and for the purpose of having everyone on the same page, it's always worth running through a bit of what is the NIH. And so this slide is a iconic front of what we call Building 1, which is where the director and the Office of the Directors primary staff reside on the NIH campus. And it was, the insert is the plaque that was dedicated for when the campus in Bethesda, Maryland started to be built or was commemorated in 1940. But the NIH actually started in 1887 as a one-room lab within what was called the Marine Hospital Service, which was the predecessor agency to the U.S. Public Health Service. The NIH mission, online and elsewhere in documentation, you'll see a number of different mission statements, but we like this one, I like this one, which is the mission of NIH is to seek fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to enhance health, lengthen life, and reduce illness and disability. The NIH AIDS research portfolio is the largest globally. It transcends all areas, including the clinical medicine and basic scientific investigation. It is trans-NIH, encompassing pretty much most, if not all, the 27 institutes and centers at NIH. It's multidisciplinary, and we have both US and international research investments. And we are considered the largest public investment in HIV/AIDS research, being about $3 billion in FY17. In FY16, for when we have the complete accounting for the behavioral and social science research, percentage of that was about 14%. The Office of AIDS research role in the trans-NIH AIDS research program, the Office of AIDS research was authorized by Congress to oversee, coordinate, and manage the program. It establishes scientific priorities, and I'm going to say that all four of these bullets are done, well, maybe the last three. I mean, the authorization by Congress is separate, but it is done in coordination and collaboration with the rest of the NIH. It is a continual process, dialogue, and discussion where we establish scientific priorities, invest research funds in line with those priorities, and distribute the allocations that graciously the US taxpayers provide. Just to show essentially that the OAR coordinates, this graphic are the institutes, centers, and offices. And this is a different image of it where the Office of AIDS Research resides in the Office of the Director. And you know many of the key institutes, but it's always good to know, and it will come up in some of our comments, I'm sure, in Q&A, about the range of institutes and missions. And it's always good as researchers in AIDS and HIV to be familiar with the different perspectives and missions of the different institutes and how they're approaching their AIDS research efforts. The vision of the Office of AIDS Research is really our vision, all of our vision, which is to advance research to end the HIV pandemic and improve the health of people living with HIV. Now, I'm going to focus on this for just a little bit because this is part of where things are transforming and moving toward. This graphic is relatively new, but really what's at the base of it are what is now called the highest AIDS research priorities at the National Institutes of Health. And you'll see, if I could do this. Well, okay, this one? All right. Actually, I'll just do it verbally, it's fine. So you can see that the four primary priorities: reducing the incidence of HIV, develop next-generation HIV therapies, address comorbidities, co-infections, and complications, and research towards a cure. Up and in behind, you see cross-cutting priorities. And then in the lower right corner is the list of cross-cutting priorities where we have essentially positioned the behavioral and social sciences research in particular to amplify and to underline that behavioral and social sciences research really cuts across all the priorities of the NIH AIDS research program. And that's an extremely important point, and that is something to hold on to and to actually, in terms of a first piece of advice, when you do your applications or you're communicating with the NIH around the AIDS research program and your role within it, it is always to your benefit to refer to how your application, your proposal, your concept, your next breakthrough idea relates to these priorities. And the other thing I want to say is that it doesn't necessarily have to be one of these priorities, that actually what you are applying for it's reasonable to say that it's reducing the incidence of HIV and its comorbidities, two of the highest research priorities at the NIH. That's actually being looked for, and it's to your advantage to include. This is also where the rubber hits the road, as we say. And you can see that, again, referring to 2016, that the total AIDS budget was just over $3 billion. The behavioral and social science research portion of that was just over $400 million. You can see in the right column, that is the president's proposed budget, where you can see that it's a considerable cut at this point in time. But as Jeff Crowley rightfully pointed out yesterday, at least the signals are through Congress, we won't know till we know, but that we will come off with hopefully something that is significantly less of a cut than what is being proposed here. But again, we won't know till we know that. In this environment and with these big question marks, I thought that I would finish out my comments with a couple of, well, actually 4 challenges and requests from me to all of you, that's really to support all of our efforts in the field. And that the first one is, again, with those 4 priorities, this is just a mock-up that I did, essentially saying, where do you see BSSR fitting under these priorities? And these are just examples. But I really ask you for yourself, with your group, with your lab, with your community research teams, to be thinking about what else can we do? Where does our idea fit? What should the ideas be that we add here? So I ask you to consider that for yourselves and in your thinking going forward. The second request and challenge actually is echoed by Susan Newcomer, Judy Arbach, other presentations we've heard yesterday and at the great mentoring day that preceded the main conference. And while it may be most difficult in terms of publishing, as a community, we really need to, while we're all doing this to some degree now, we really do need to be looking to see how do we get our messaging across about the value of behavioral and social science research and in ending the AIDS pandemic. And I say, especially in non-traditional venues, and you heard, I mean, the Harper's and The Economist was brought out. I think that's perfect and that's great. But a non-traditional venue can also be the biomedically oriented brown bag lunch at your lunch that's held once a month at your university, and say, well, why don't we shake it up? I'm going to bring some interesting ideas into this and talk to the folk that are maybe across the hall down the street. Because we actually, as we're moving more and more into integrated approaches, as we're trying to make sure that our biomedically oriented colleagues understand that, yes, we absolutely have a lot to work together on in terms of the support of, for example, biomedical technologies, whether it's adherence or recruitment, but that is true, and the behavioral and social sciences have basic science research. We heard about Sabi yesterday, and many other examples to provide. And that was also the rationale and the motivation for Dr. Michael Stirratt and I to do the paper that came out in the August issue of JADES, where we made the attempt to outline the roles and opportunities of behavioral social science in HIV/AIDS, both for the community to be able to refer to, whether it's in applications or in their discussions in non-traditional venues, but also to speak to the non-behavioral and social science research communities. The third request and challenge I have is, when you think that something that rises above, that's a breakthrough in behavioral social science research having to do with HIV/AIDS, that needs to, that should be brought to the forefront, I actually ask if you would just try to summarize that the best way possible and send that to me. That can be across any and all of the high priority areas, across basic and applied research, and as they may be portrayed, conveyed, utilized, implemented, demonstrated in behavioral and social science-based programs and policies. And those ideas, breakthroughs, packaged and sent to me. I know it's going to be not the full, but you'll send me references for further information. Go ahead and please send that to me. This is my NIH email, and also to Amber Wilson, who works with me in the Office of AIDS Research, because increasingly, and this isn't just an internal NIH message or an OAR message, but I think it's pretty universal, that we have a lot to offer. We're doing a lot. We will be doing a lot, and that we need to begin to articulate that and begin to put that forward increasingly. I know we're doing it now. I know that's part of what all of our work is about. But part of that recruitment internally, I will utilize that. Judy continues to work on these efforts as well with me and with the Office of AIDS Research to get this messaging across. And increasingly, it's really about show us essentially where that evidence is and how this is fitting into the rest of the picture. Because then that can be utilized as metrics, as evidence, as information to defend budgets, to help budgets grow, to bring into the argument for continuing the SBSRN and maybe even growing that as well. And with that, I thank you. And NIH turning discovery into health, and I appreciate all of your commitment to the work that you do. Thank you very much. And Rick has some comments.
I just have a few comments.
Yes, oh, that's great. Thank you, Paul. So next up, we're going to hear from Rick Berzon from the National Institute of Minority Health and Health Disparities, and he's going to tell us from that institute's perspective what is of interest and what they focus on. And you're welcome to come up here, or you're welcome to stay down there, whatever you're comfortable with.
So I'll stay here, and okay. I don't have any slides. I just have a couple of comments, given that there was quite a lot of discussion yesterday around the topic of health disparities. And so I just wanted to introduce you a little bit to the National Institute of Minority Health and Health Disparities, which is a relatively new institute. I think you all know from Paul's presentation, and I'm sure before that, that there are 27 institutes and centers at the NIH, and there's quite a lot of overlap. And actually, many of the larger institutes and institutes at NIH have offices of health disparity research. So although that's an important part of our mission, we're not the only institute at the NIH that does work in this area. So that's just something that I'm sure you all know. Our mission really is to lead scientific research to improve minority health and eliminate health disparities. And we're a little bit unusual in that we've been charged to plan, review, coordinate, and evaluate all minority health and health disparities research and activities of the National Institutes of Health. So we work very closely with the other institutes and centers to try to make that happen. When I say we're new, we actually were created as part of the Affordable Care Act legislation, and so we're about 7 years old at this point. We are very much focused on issues that relate to behavior and social science. We focus on health determinants that lead to specific outcomes within one or more racial, ethnic, minority groups, and I'll let you know who they are in a second. And we focus on understanding and addressing poor health outcomes in health disparity populations. The current NIH designated health disparity population roster includes racial and ethnic minorities, socioeconomically disadvantaged populations, underserved rural populations, and sexual and gender minorities. When I cite minority health populations, this is actually something it's not identified just by our institute. There are other agencies within the U.S. government that play into this, including, interestingly, the Office of Management and Budget, as well as Census. But these groups include African Americans, Asians, Latino or Hispanics, American Indian or Alaska Natives, Native Hawaiians or other Pacific Islanders, as well as the groups that you wouldn't necessarily think of that I just cited: sexual and gender minorities, underserved rural populations, and socioeconomically disadvantaged populations. In terms of what's important to the work that we do at NIMHD, our priorities include what you would probably suspect, given what I've just said, that we're interested in issues that relate to health disparities research in terms of, like, for example, social determinants of health in targeted populations, and with respect to some of the conversations that took place yesterday with respect to HIV. Of particular interest to us are things like stress, stigma, discrimination, lack of access to culturally competent care. Those are just a couple of very broad areas. I mean, adherence, prevention, all these areas that you would think are of interest to us. And we're interested in basic clinical and behavioral research on minority health conditions, including research to prevent, diagnose, and treat those conditions. So we have a strong interest in HIV, but of course it's not our only interest, and we're one of the smaller centers with one of the smaller budgets. So we can't do everything, and we have to carefully review the applications that come our way. I'll let you know that we do have a few. We recently did an RFA on engaging youth and young adults from health disparity populations in the HIV treatment cascade, and we received not as many applications as we would have liked to have received, but we did fund 2 of those in August of this past year. And just to let you know that we have 3 other RFAs that will be posted in the guide probably within the next month, I'm guessing. And I'll just tell you that one is RFA MD 18002, which is mechanisms of disparities for HIV-related comorbidities in health disparity populations. And I can tell you that the initiative will support research to determine underlying mechanisms of how HIV-related comorbidities may influence the complexity of HIV/AIDS disease progression, quality of life, and overall health outcomes among HIV-positive individuals from health disparity populations. A second RFA that we will post is RFA MD 18003, which is on research on pre-exposure prophylaxis, or PrEP, to prevent HIV in health disparity populations. And the purpose of this initiative is to support community-based and healthcare setting research to understand the individual, interpersonal, community, and societal factors that influence patterns of PrEP attitudes, access, availability, and adherence among health disparity populations in the U.S. And finally, we have one other HIV-related RFA that we'll post, which is entitled Prevention and Treatment Research to Address HIV/AIDS Disparities in Women within the U.S. And that initiative is to support health services intervention and implementation research to understand and reduce racial, ethnic, geographic, and socioeconomic HIV disparities in U.S. women. That's just a little bit about our institute and what we're interested in and what we're likely to fund. And I'm sure there'll be general discussion, and happy to answer questions. Thank you.
Rick, one follow-up question to that. So are you the contact person for these RFAs? And I know that'll be listed on the, once they're released.
I'm the contact person for HIV/AIDS
overall,
stuff.
so those would fit in there. Great, okay.
Right,
And
I worked with the other program officers to make these happen.
And are those, once they're posted, are those going to be for January submission date, or is it?
Later.
Later than that, okay, good, so it's not that rushed, okay. Do you want to say something?
No, I just want to invite
Yeah.
Susan and Willow up to the dais.
Great, so as they are joining our panel, we have the luxury of time to pose questions to our NIH officials here. We have a great representation. I'm going to ask Willow to introduce herself in a moment because we've got an introduction from everyone else. And I also thought, Judy Auerbach, I may put you on the spot occasionally because we do not have anyone from NIDA, the National Institutes of Drug Abuse, and Judy sits on their advisory council. She's not a federal employee, and she's not officially well, it's an official role, but it's not a federal appointment. Well, it is a federal appointment, but she's not paid by the feds. So, but she'll have a perspective on what goes on, at least on the council side, from NIDA discussions, and NIDA does have a very large HIV portfolio, and so it'll be good to have their voice in this. You're welcome to join us if you'd like, or we could just pitch questions to you there. So why don't we, Willow, can you introduce yourself?
Yes, I'm Willow Pequenaugh. I was not named after the tree. I was named after my father, who was a Willis. So that's why there's no W on the end. I was very, very fortunate after I got my PhD to go to work for NIMH when it was just an emerging program. And the then director, Ellen Stover, told me, you can either have a big budget and no staff. I was the first PhD she hired, or you can have a big staff and no budget. And I think we're getting to that tipping point where there's more AIDS program officers per dollar than there used to be. I was fortunate to be there for 26 years and work with really amazing people, and I really thoroughly enjoyed it. Now I retired. I started a company, Salix Health Consulting, Inc., and as NIH begins to change prevention programs into clinical trials, they're going to need external quality assurance monitors, and that's what I would really like to do. I love to work with protocols and see if they're being properly implemented. And it's just a delight to be here at this meeting. And as somebody said yesterday, see that the next generation is coming along, and they're very impressive. So good for you.
That's great. Thank you, Willow. Willow was my program officer when I was a graduate student for my dissertation, and that was a couple of decades ago. So she's had a profound impact on my trajectory. Whether she realizes it or not, I was probably just a glimpse of an email at one time or another, but she had a hand in that. Let's open the floor to questions from you. It could be directed to the whole panel or one in particular. Who'd like to start us off? Susan. If you would, please, just to make sure we can hear you. Although I guess we're not recording, so I think our NIH staff can be a little.
Can I also make a few comments?
Of course. Oh, Willow, yes, Willow.
Well, after
Susan, do your question. We'll start with Susan, and then Willow will give us some semi-opening remarks for her.
Right.
No,
Sorry,
Can
Willow.
Susan
No.
say, I'm just
I've
going
known
to
you
say,
for a couple of decades, too.
Happy to.
I'm just going to emphasize before we really get rolling that Susan and Willow are here as former and retired federal employees, just to underscore that, because I do not know what the next thing they're going to say.
Well, the other thing is what we had to put on all of our publications. This is our personal opinion and does not reflect the policy of NIH.
You know, I can take a seat and you can
No,
give
no,
your...
no.
Okay.
Go.
So the question I have is, when I am or my mentees are trying to figure out what institute to go for, it seems like a critical bit of knowledge is, or information is, how large an ABES budget is there? So if you're going to NIA or NICHD or NIMH and you're trying to say, well, you know, the ideas could go in any one of these places, but of course, the size of the budget, as well as, of course, the interest in social behavioral issues, really is an important thing to consider. But as I ask around, I never can figure out where the information is.
Well, I think you need to know the pay line as well, because some people have a bigger budget but a very low pay line because a lot of their budget goes into cooperative agreements. And so they have little left over for R01. So that's one thing. Second thing is what are their priorities, and can you find a program officer that you feel comfortable with, who you feel will be your advocate in the room when you're not there?
Yeah, and also to your point, first about this and probably a lot of other questions that will come up, everyone's aware of NIH.gov online, which has sort of essentially a lot of what you want to try to find out, which will have mission statements of the institutes, which you can actually find where there is some budget information. It won't drill down probably to the level of what you're asking about, but what it will also do is give you contacts, and of course in any of the announcements, the program officers that are listed. But I think in part what you're asking about is also unsolicited, right? And just getting a handle on who the program officers are, because in my experience at NIH, one of the things that I think is a good thing and tends to work well is that the program officers, while they are committed to growing and developing their particular areas of science and bringing in investigators and helping to support them, and that's really also critical to know that the role of the program officer really is a support role to you, and they have a metric that they're judged by, which is how healthy is their portfolio, how well are they bringing people in, what was the response to their FOAs, and so they have skin in the game around that, and so it's really a facilitative role, even if at times it doesn't feel that way. But one of the things in my experience has been that a program officer, especially within a program or an institute, when they talk with you and they hear this, they may actually say, you know, this is really interesting. I actually think Dr. So-and-so or Ms. So-and-so would be the right person to talk with. And so they may refer you over. And that's not, you know, a shuffling of you away. It's actually to try to help you. And the program officers and former program officers here can speak to this as well. But it's not uncommon if they also may say, You know, we can't do that here in our institute, that we're not shopping that right now, but you know what? NIDA might be, and you should call such a person. So I would not be hesitant to say, if you don't, you know, if you have a great conversation and it's working, then I also think it's fair to say, well, in the current budget climate, and your budget and your institute's priorities, how does this all fit in? The thing to realize, program officers, like a coach for a game, they don't know who's going to win the game. They're there to help and coach you and to work with you, but they can answer some of those basic questions to the degree that they can.
So I just want to answer your question briefly, but I try to give you also some practical information, which is that the RFA that you read when you come upon it will oftentimes, if it's a set-aside initiative that the Institute put out, they're very interested in that topic area, like the three that I mentioned with respect to HIV. So we're very interested in those areas, PrEP, comorbidities in women, as an example. And it oftentimes says within the RFA, you know, we're going to fund a minimum of 3 or 4, whatever it might say, within the material that's there. We're going to fund 3 or 4 applications from this proposal. The other thing I want to, so it's oftentimes written, so you can have an idea of exactly how important it is to that institute or center. Or I should say institute, because centers don't have grant-making authority. The other thing I want to say is that, and I think everybody knows this, that there's 27 institutes and centers, and they all have a website. And you can click on it and sort of go through it and see who is the program officer, and follow up to what Paul was just saying, for a particular area around which you might have an interest if you're just doing this cold. And you know, program officers like myself vary in terms of what the kinds of questions that we field from interested applicants. I mean, some people feel you have to have everything already written down, and I don't feel that way myself. If you have an idea, you want to sort of kick it around a little bit and brainstorm it, that's fine. As long as I have the time to do that with you, I'm happy to do it. And talk a little bit about how you might put a proposal together that relates to the initiative around which you're interested. So it's kind of a fluid process. I don't think there's any hard and fast way to do that, and it sort of depends on who you get on the phone. And you know, some program officers would prefer that you send them an email first and whatever. But so I think it's quite variable. It all depends on how comfortable you feel. The other thing I just want to say is, with respect to the slides that Paul put up, with respect to cross-cutting priorities and areas of interest, that health disparities research was one of the areas in there.
Cross-cutting.
Yeah, cross-cutting. So in terms of areas that NIH is funding with respect to HIV/AIDS research, that's one of them.
Willow.
Okay, I'd just like to make a few quick points. One is the program officer, especially if the person's name is on the RFA or the funding opportunity announcement, is probably the most knowledgeable about the science of the call and the priorities of his or her institute. But beyond that, they may not have very much expertise about deadlines and how to submit in the electronic system. So, and just because you call a number at NIH, it doesn't mean that you're going to get expert information. It's best to triangulate, because I've had people who called, they got one person, they got the wrong submission date, and they lost the opportunity. So triangulate the information and really confirm, and if you get it on the website and it's in the announcement, you're probably on safe ground. My advice to people is, I know we all abhor a blank piece of paper, but don't start writing until you have the logic of your application. I've seen people who sit down and they feel so good because they've written 20 pages. But that's where mistakes creep in, because you're going to talk about it, you're going to change one section and forget to change the other. And at the review, they love to look for inconsistencies. 26 here, 30 there. Typos, you know, there's always somebody who likes to count the typos. You can have 1 ding, 2 dings. By the time you get to 3 dings, people are saying, can we trust this person with the data? And that's what we're buying. We're buying your data and your analysis. And if you allow error to creep in, the product that we're going to get is not what we paid for. Also, the other mistake I think beginners make is they think they have to accomplish too much. You're a lot better to stick with one idea and be consistent through it. And at the end, you can put a catch-all that talks about the exploratory issues you hope to find out about in this proposal. But don't put in multiple studies. And as a beginner, try not to go to multiple sites, because every time you add another site, especially one in another city, you buy yourself a whole bunch of problems in terms of they can ding you because they're not comparable samples, and there'll be a long discussion about that. And by the time they're through with that discussion, they're through with your proposal too.
Willow, can I make a comment on that?
Sure.
Okay, so Willow referred to the beginners, and so what I want to say is this room is really a wonderful mix of early career investigators, mid-career, and veteran investigators. But I want to say that at the NIH, early career investigators, that's actually a term that has value and merit increasingly. Discussions internally at the NIH is really around how do we support the early career investigators, how do we build the pipeline, and that they're really trying to figure that out. And for the folk who haven't come upon this yet, again, we keep referring to the website, and because there's tools there. For one thing, you can put in, with what Willow is saying about your idea generation and the formulation, it also needs to be responsive to the mechanism that you may be considering applying under. And on the NIH website, you can put in grant mechanisms, and there's basically a tutorial, a primer, a dictionary of the mechanisms, which is really good and important to know. And then this black box of the review process. We talked about this in Mentoring Day, actually, which is that if you, again, can find it through NIH.gov, but if you put in the search term of mock review, mock grant review process, there are YouTube loops, there's videos that actually, let you sort of virtually watch and be part of what the review process is, and just familiarizing yourself with what that internal process is, I think helps to make you better grant writers.
The other thing is probably only 5 or 6 people will have read your application in the review. So, but everybody has their favorite part of the application. And so you better put in clear headings and make your application easy to scan, because they're sitting there trying to listen to the discussion of the primary, secondary, and tertiary reviewer, and they're trying to find their favorite section. We had one reviewer who, if he read every single data analytic plan, and if he couldn't derive the study from the data analytic plan, you were, in those days, voted a 5. It'd probably be a 10 now, but so be very careful in your structure. More words is not going to communicate. It's really going to bog down the reviewer who's trying to figure out what you're planning to do. The other thing is, believe me, there's going to be another witch hunt for sexual sexual behavior HIV grants, your title and your abstract will be read by hundreds and hundreds of people. And so be, yeah, they're not, but be careful. Try not to put keywords in your title and in your abstract so that when somebody goes through, they can't find your grant. We funded a grant in bathhouses here in San Francisco, and we never called them bathhouses. We called them social clubs, and we made it sound like it was a country club, you know, where people were just socializing and exchanging information. So be very, very careful about what you put in those two places. The other thing is diversify. We've had many investigators who started out with us in '89, or before that, '85 actually, who've never been funded by anybody else but NIMH. But that is not a good strategy these days. Diversify. I had a researcher who had a wonderful cohort of MSM, and they came out with a cancer FOA, and he looked at it and he said, well, I could put in and see how many of the men in my study have prostate cancer, which had never come up before. And there he had all the behavioral data he needed, and so he put in a grant and was successful and was able to really correlate the behavior with the prostate cancer and so forth. So diversify. Cheryl Boyce is now, who used to be at NIMH, is now at Heart, Lung, and Blood. Get in touch with her. Almost all of you can work out something that crosses over with Heart, Lung, and Blood.
And Willow, also on that, just a structural comment that really is important for folk. And then I think we'll take a question or two, and then we'll loop back to other comments that you may have. Is what Willow's point is actually a really good one, where we have the dedicated AIDS research budget. It does make sense, as I was saying, to know what the AIDS missions of different institutes are and to be familiar with that, and to realize if you get funded by an institute, that does not become your dedicated swim lane. I mean, you have other options, and to remember that for your career building. And then there's also the AIDS budget at NIH represents about 10% of the overall AIDS NIH budget. There's non-AIDS announcements that come out that will accept and consider AIDS-related applications, so long as it meets the goals and objectives of what that announcement is. And so that is also, you can stretch as well beyond even the AIDS program, and keep an eye on what those other announcements are about. But let's go ahead and take a question and keep your points, and we'll loop back around. Is that okay?
Sure.
So, is that all right? Good.
Hi, I'm Sarah Wilson, and I'm an early career investigator, and I wanted to follow up on some of the things that you all have been saying that were specific to people that are in that position. So one of the things that I've been thinking a lot about is that there's a sizable proportion of people that do get NIH funding for, say, an F or a K that don't end up going on to get an R or go on to get an R01. And so I was curious about what your perspective was on that, in addition to some statistics about the mean age of when people actually get their first R01 being quite far sometimes from when they first started their career. And I know that NIH is doing some things to try to, as you said, kind of grease the pipeline for early career investigators. And so I guess my question is, what advice do you all have for trying to make that transition from being an early career investigator to being a mid-career investigator and having a more established research portfolio, and how to grow that in a way that's sustainable? Thanks.
Well, I'll take a beginning stab at that. Remember that this early career investigator advantage is for R01s. It is not for Ks. It is not for RO3s. It is not for R21s. It is and the different institutes, it is a 2 or 3 percentage point sort of granted additional boost for a first-time RO1 holder. Other than that, the early career encouragement is basically the issues around the call for K awards, the call for F32s, postdocs, and those are ipso facto new people. But the RO1 is, you can be 68 years old, and if it's your first RO1, you are an early career investigator or a new investigator. So it's the RO1s that the application process gives you a little edge. The rest of it is you have just got to sweat blood like all other applicants do and compete with all the other people who are looking for Ks or small grants. In that sense, there's no edge, except you're honing your own personal skills.
Publish, publish, publish.
Yes.
So
Get Willie McFarland's listing on how to write a paper.
So NIMHD is committed to the training of a diverse scientific workforce. Yes, of course, we look at RO1s, but we also look at we look at Rs, Ks, whatever. We're committed to diversifying the scientific workforce and trying to bring people into that workforce that in the past may have not had those opportunities.
I don't want to put her on the spot, but it looks like I think I'm going to. One of the many people that I've had the good fortune to know and to work with who's here, who I see as an NIH success story through her hard work, grit, and hopefully a lot of you in this room are going, that's me. I'm hoping that's what you're thinking. I'm gonna highlight one person in particular and ask her if she had any comments, and that's Dr. Susan Sherman. Are you here? Would you have anything that you would want to say about your progression? I'll look at her. So she, as a success story, because I'm not sure if where you would consider yourself in your research career, but would you come to the microphone and? What do you want me to say? Well, about essentially your journey from your beginning.
Oh my God, there's so many other people.
And no, this is just one success story of many.
Well, I will say, and both Willow and Susan have been project officers of mine, when you mention a grant being pulled, I thought it's the way my dean learned about me early on. I had a grant. Unfortunately, put the word sex workers and microfinance in the title one of those terrible summers, and it was a supplement, and it was pulled. And it was pulled, they didn't even have the dignity to send a letter about that grant. It was kind of about another grant, because they mentioned how it was inappropriate to have something in the intervention that didn't exist. So never a good way for your dean to learn who you are. Luckily, I survived that. In Hopkins, it was the first time we had funds taken away. So it really does count what's in the title. And of course, there are always high-risk women now. I don't know is that the story you wanted me to tell?
Well, also, I think that, just in terms of your mechanisms and how you progressed, but Susan is also a person that also underscores a willingness to take a chance on things that might be dicey in terms of a research topic. And we're in HIV/AIDS. Imagine, do you think we have some dicey topics to be covering? And essentially, part of what I'm referring to is essentially in Baltimore, there's an area called the Block, and Susan just said, we have to be figuring things out for these women and for the people who are living and working there. And you want to talk about that a bit?
Right. So that's a block of exotic dance clubs. I don't need to tell them. I'll just tell everyone here. That basically function as brothels, and it's kind of the inextricable link between drugs, the drug economy, and the sex economy. And Paul was really great and gave us funding we didn't have a formal mechanism, but he created in the days when people had power to do this, a mechanism to give us a tiny bit of money to do ethnography amongst these clubs. I mean, I guess the long and the short is like, always stick with your passion. Some people, I've never played it safe because safe doesn't really interest me. No, I mean, you know, because I'm interested in populations like sex workers in Baltimore that no one's doing any work with, or police in Baltimore around how they police sex workers. So I think the point is, particularly when you're junior, is if you have something that drives you and you know why you're here, go after it and you'll always find advocates. Like, actually, 3 of the 5 people up there have been great advocates. Willow fought for a grant that for years, 3 years, we tried the Indian government to approve, and they never approved also about sex workers. So that was more money. I've given a lot of money back to the NIH. But anyway, I think that's kind of the message.
Thank you so much, Susan.
I had one follow-up to this topic. From what I understand, there's some formal mechanisms to help what I guess the NIH is calling early established investigators. And I just recently learned about that. And these are people who have gotten their first R01 and maybe are struggling to continue from there. So it speaks to some of the sustainability questions I think that were in the earlier question. Has there been, do you guys have any comments about that? It was news to me when I learned about it just several weeks ago. Any comments about this early established investigator priority or considerations?
News to me.
Is it?
Yeah.
No.
I don't know about that, but I do know that, as was said here already today, that NIH is committed in general to early career investigators. They're committed to diversifying the workforce, and I think well, my understanding is that the whole process of review and who does the reviewing and all of that is under scrutiny and is being looked at to be revamped to try to accommodate the changes in attitudes. So I think that's happening, but I'm not aware right now of a formal mechanism.
This relates in how to build your career. Many of you represent populations that need to be represented on the grant if the PI is going to do work there. And we had a PI who submitted, and they said, you have no Hispanic on this application, but you're intending to work with the Hispanic population. So he called me and he said, who should I get? So at that time, Hortensia Amaro was very hot. So he called her, and I was amazed at her. I mean, she practically wrote a contract with him. She was not going to, if she was going to lend her name and her expertise, she was not going to be a token. So she had that she could add this many questions to the questionnaire, she could do this little sub-study, she could be on the following papers, and that she would be an integral part of the scientific team. You are very valuable to many investigators who really need your expertise and your presence. So don't accept talks at too many conferences. You can waste a lot of time traveling to and from conferences. You know, if you don't have tenure yet and you haven't reached associate professor, you know, look at every opportunity not as, oh, wow, they want me, and look at it, what will this do for me?
Thank you. More questions? Or did you?
Oh, I would like to make a pitch for the maternal and pediatric infectious disease branch at NICHD, which funds a fair amount of research on mother-to-child transmission of HIV and on adolescent risk behaviors, adolescents of all races, genders, gender identities, sexes. Think about that as another place to consider for your work on young people. And also, I know it's as I said in the mentoring day, it's heretical. There is, if 10% of the NIH budget goes for AIDS, 90% does not. you can also expand into the rest of the research world, because many of the populations that you are interested in don't just suffer HIV infection. There are a lot of other things that go on in those populations, whether or not they're AIDS related. So do not constrain yourself, especially in this world when the proportion of the budget that's AIDS related is going down. As Willow says, think about yourself, think about your career.
Now I'm gonna interrupt Susan and say, we need every behavioral and social science researcher in HIV/AIDS, and do not abandon the ship in any way, shape, or form. And to say to you that there's more than $400 million on the table, and even with a cut, there's going to be substantial money for funding behavioral and social sciences research through the NIH, in our effort and the critical contribution of our sciences to ending the AIDS pandemic. So I just have to say, just don't abandon this. So, and I also want to say, given Mentoring Day and the idea generation and presentations that came through on that day, the presentations yesterday, the posters that are in the back of the room, you know, the president talks about the State of the Union. Well, I think the state of our science is strong, and I think that we are, I'm going to say something we don't know, underappreciated, and our place is integral at the NIH, and I think we need to begin to co-opt the folk who can also help amplify our message, which actually may be your biomedical colleagues, in integrative research plans, in beginning to say, you know, I think I could make your study better. So I think we also have to adopt our own new behaviors in getting our message out, getting integrated, and developing our own growing behavioral and social science agenda in AIDS in our communities.
You know, let me just say, Paul, that your group is the one that really lends support to other institutes at the NIH, and maybe given the fact that there are so many institutes, if people are just starting out, they maybe not sure of which one to approach to have a conversation with. Perhaps you might want to just share with people what institutes are the ones that receive substantial funding?
I'm actually going to take your question and change it just slightly, that I really don't think, I mean, okay, in some ways size matters, right? But in a lot of other ways it doesn't. And when you have a small institute, for example, the NIAAA, Alcohol Abuse and Alcoholism, they're doing key critical AIDS-related research. And to say they have a small AIDS budget, so I'm going to go over to the big guy across the street, it really has to do with the alignment of your concept and your research idea with the goals and objectives of that institute. And I would adhere to that more than whether one institute has more AIDS than the other, AIDS money than the other. And also, I do believe, again, I'll hark back to what I said before, is that while the NIH is a federation, you know, there's a lot of fiefdoms. The institutes are a little bit like fiefdoms. They are also a team, and that they're also, they also are familiar with what, to greater or lesser degrees, and as has been said by this panel, to greater and lesser degrees, depending on what program officer you're talking to, are familiar with other opportunities that may even be outside of their institute, and will guide you there. So.
Great, thank you, Paul. We have time for one more question, and then it's time for our break.
So my question is actually in this topic of whether HIV or other things that are relevant for a population. I'm very interested in transgender women, and there is a population for which there's very little research on everything, but most of the research that exists is on HIV. So that is a population that as a group, I'll be interested in finding out about other health-related issues, but I do recognize that HIV is a relevant issue for that population. So my question would be, what would be the pros and cons of going on a general health path versus an HIV-specific path, given that my interest is mainly on the population and the health of the population, and then specifically on HIV. So what's...
Is it okay if I take a stab at that? So thank you for that question. One of the things, first of all, within the AIDS research program, increasingly around comorbidities or multi-morbidities, we're seeing the coalescence around, syndemics, number of different types of factors, health factors. For the AIDS support, whatever is put together, it still needs to have HIV at its center as its focus, recognizing that this study is really bringing in other factors and may benefit other health factors along with HIV, but what is the tie-in to HIV? So that's one thing in that regard. The other, specific to what you are asking, is that it also depends on finding where that is at the NIH. And so, for example, recently developed is the Office of Sexual and Minority Health Research within the Office of the Director's level that actually has programming that is AIDS and beyond AIDS for sexual minority groups. And so again, my go-to is go to that NIH website and look that up, and they have announcements, and it's been 2 years now, and I believe it will continue.
They don't have any money. They have very little money, that office. But there is a program announcement out, which I'm sure you know about, the one on transgender health, which has 11 institutes signed on to it. So in that sense, as I said, there is money outside of AIDS money that is, and the institutes that are interested in transgender health. And so it's basically your call on how you want to pitch it, because there are, I think, 11 institutes that have signed on, and there are 11 program officers. You might as well call them all and ask about, what their interests are, rather than thinking about, one of the issues behind that, I don't know, this is treasonous, but behind that call, plus the first call for research on sex and gender minority health, was to say, unfortunately, there is far too close a link between being gay and being HIV positive, and we need to push the issues around health of sex and gender minorities, not simply reproductive health, not simply STD health. So again, it's go with your passions, go with your skills.
Thank you, Susan. Willow, we're going to give you the last word before our break, but I just want to say, just underscoring what so many of our panelists have said, the program officers and the officials in other capacities at NIH are there as a resource, and don't be shy about contacting them. They're human, so they may have different ways of how they prefer, sort of human, how they prefer to interact in terms of how much thought you've given to your topics, but don't be shy about contacting. If they're not the right person, they'll point you closer to whoever that person is. Willow.
Well, you can see how much we like to talk, too, so call us. No, don't call me, I'm not there.
Were you here?
If you get a good score and the institute decides to fund the project, the agreement is a contract between NIH and your institution. And as long as you deliver what's in that contract, there's usually money enough that you can easily do other things, and it's a way to publish more off your grant. If you collect, it's not cheating, it's adding a few more questions here, and just so that your hypotheses are covered. So it doesn't end up being a secondary data analysis where you're using something that was designed for one thing to answer another question. You can have it in there. Also, you know, you don't have to tell NIH everything you're going to do, and you're better off if you don't. No, I don't mean that in a devious way, but you know, keep your proposal simple, but collect data that might help you answer other questions.
As long as you get IRB clearance.
Oh, yes,
All right.
always.
Thank you, Willow. Thank you, Susan. Thank you, Rick. Thank you, Paul. Thank you, Mallory.